Good evening, everybody. It's my pleasure to be there for a nice echocardiographic conference, East Zone Echocardiogram. I thank the organizers for inviting me to discuss something very interesting. While doing echocardiogram, we frequently come across some surprises, and my talk is based on three such surprises. The first case is a patient, 5-month-old child weighing 5.2 kilogram. He was referred to us for CHD, diagnosed one for surgical intervention. The child was tachypneic and tachycardic. He was cyanotic with saturation of 69%. Second heart sound was single, and there was 2 by 6 ejection systolic murmur in the left second space. X-ray showed cardiomegaly, and we can appreciate increased pulmonary blood flow features. The ECG showed right axis with RVH features. So the referral diagnosis was total anomalous pulmonary venous drainage, that is TAPVC, coronary sinus type. There was mild TR, dilated RA-RV with severe pulmonary hypertension. So we started evaluating. In the initial echocardiogram, we found RA-RV, we can appreciate they are dilated with RV pressure elevated. The tricuspid jet showed RVSP of 70 plus RAP, and there was a common chamber we can appreciate behind the LA. In the subcostal view, we can appreciate there's a significantly dilated coronary sinus with obstruction having mean gradient of 6 millimeter of mercury. So the diagnosis, what with the patient came was looking appropriate and matching with the clinical scenario. TAPVC to coronary sinus, but we found significantly dilated right superior vena cava with brisk flow. So when there is TAPVC of the coronary sinus, there should not be increased flow here. So we thought there may be possibility of an additional vein going up, but additional vein should not cause that much increment in the RSVC flow. So common chamber, we kept on evaluating, and we found there is a vertical vein above also. And that vertical vein, we can appreciate all the four veins are uniting. This is the common chamber, and it is elevating by left vertical vein and draining via RSVC back to RA. And this is the lower vertical vein. So we are coming across an extremely rare type of anomaly where a common chamber is draining both via superior and inferior vertical veins. So we got a CT scan done, and CT clearly showed the TAPVC via left vertical vein and by inferior vertical vein. And this is the 3D reconstruction. This is the large, look like aorta almost, but this is the aorta. This is the ascending left vertical vein. This is the descending vertical vein, and both are obstructive. The patient underwent surgery by successful anastomosis of common chamber to LA, discharged on day 7, and high index of suspicion required for the diagnosis during presentation. And detailed evaluation in addition to cardiac imaging is essential to strategize the surgical intervention. Our next patient is a lady, 41 year of age, weighing 61 kilo. She had effort intolerance since 2011 with increased symptoms few months before presentation. She had pedal edema, no chest pain and LOC. She essentially was referred for device closure of diagnosed atrial septal defect. When we saw, she was saturating well, having good normal BP, but there was pedal edema, which was little not common type. Pulse was normal, second heart sound was normally split, and there was no murmur. The ECG showed sinus rhythm with RSR pattern. X-ray showed cardiothoracic ratio of 0.6 with some parahilar congestion. So initial transthoracic echocardiogram showed there is a small atrial septal defect. And interestingly, in the four-chamber view, we have not found significant right ventricular inflow dilatation. There was mild tricuspid regurgitation with a estimated pressure around 36 plus 10, 46 millimeter of mercury. While doing the echocardiogram in follow-through, we found dilatation of the right ventricular outflow tract. And though RVOT was dilated, MPA was not dilated. This was again not matching with the initial finding. So T transthoracic echo raised more question than answer. We had 8 millimeter ASD, left to right shunt with mild TR. The RVOT dilated, not inflow. No MPA dilated, and echogenic RV papillary muscle having mild RV dysfunction. So FSE was around 20%. So we planned for doing an TE. Transesophageal echo showed a restrictive AHD with an aneurysmal interatrial septum. We can appreciate the restrictive gradient of the AHD. The left ventricle, as we found in transthoracic, was dominant, but the outflow, as we found in transthoracic, was dilated. So similar type of finding in the transesophageal echo, we were still not clear what we are heading, and we planned to get a cardiac MRI because why there is an isolated RVOT dilatation. Our MRI gave the answer. There was sacculation in the right ventricle wall, anterolateral wall. There was accordion-like feature. The MPA was not dilated, though RVOT dilated. There was delayed enhancement we can appreciate in the right ventricular wall. These all are suggestive of early arrhythmogenic right ventricular cardiomyopathy. There was fibropathy changes, the normal and fat suppressed image showing these fibropathy changes, which are very, very characteristics of ARVC. So final diagnosis was dilatation of the right ventricular outflow tract, patchy fibropathy infiltration of the RVOT with small AHD, mild RV dysfunction by cardiac MRI found EF 38.5%, whereas LVEF was normal, and early changes of ARVC. So we treated her with beta blocker and diuretic. She was on follow-up for 1 year, significant improvement of symptom, no effort intolerance, edema disappeared, no palpitation, which she considered after starting the therapy that she had palpitation earlier. So 1 year follow-up, same thing, we again evaluated, no RVOT dilatation, and RVOT dilatation, no inflow dilatation, significant increment in the RVOT aneurysm. The RVOT long axis, short axis measurement around 19 to 21 millimeter per meter square. RVOT outpouching was a new development. We can appreciate this is an outpouching. In the cross-sectional view, we are showing that. The ECG in February 2020 showed low amplitude signal between QRS and T in V1, V2. We can appreciate this was not there in the earlier one. We can appreciate a low amplitude signals. So if we compare the three ECGs during 3 time, these are the slow changes appearing over time, and that is the crux, that it was not there when we started seeing the patient. So ARVD can present with varied symptom. Associated AHD can divert attention from ARVD. A detailed clinical imaging evaluation can help to identify early ARVD. Cardiac MRI is the gold standard, and serial and continued follow-up assessment is essential. Early diagnosis and therapy is always rewarding. The last patient is a 15-year-old boy who came to our OPD in wheelchair bound, significantly distressed and cyanotic. He was only weighing 30 kilo at 15 years, saturating only 72%. Heart rate was, in spite of distress, 70. There was soft systolic murmur. He was unable to lie down. You can appreciate the fingers, which was a little clubbed and saturation 72%. ECG showed sinus rhythm with significant RVH and strain. There is T inversion in V1, V2, V3 suggestive of significant RV strain. ECG showed cardiothoracic ratio 0.6 with parahilar congestion. Initial laboratory evaluation was hemoglobin very high, 21.2, bilirubin 3.3 milligram percent with normal enzymes. Initial evaluation showed PFO right to left shunt with significant thickened hypertrophic right ventricle with dysfunction. The IVC was congested. There was severe RV hypertrophy we can appreciate in the four chamber view as well as in the short axis. The RV systolic pressure appeared high. The TAPSE was low. In continuation, we found minimal pulmonary antigrade flow and RVOT gradient. We found 166 millimeter of mercury, which was extremely high. So the diagnosis was very severe valvular pulmonary stenosis gradient more than 160 with minimal flow having annulus of 14, severe RV hypertrophy and dysfunction, PFO right to left, and dilated congested veins. So we took him for cardiac catheterization, and as we thought, the right ventricular systolic pressure in the cardiac cath we found 217, which was much more than the aortic pressure. Aortic pressure was 140. The PA pressure was only 18. So there was actually 200 gradient across the RVOT. We can appreciate the pinhole type opening in the right ventricular outflow tract injection. So it was a critical type uh, uh, valvular stenosis. We dilated with a Tyshak 2 balloon, initially 18 millimeter, followed by 20 millimeter, and the waist gave away. Post injection, you can see the pinhole has gone and the RVOT is well open. The gradient significantly reduced from 217, it came down to 84. The PA pressure from 18 increased to 34. So the gradient was 50 only from 200, and the saturation on table increased to 97%. So significant improvement happened after the balloon angio. But the patient was shifted to ICU. 6 hours down the line, patient again developed significant destabilization, desaturation, significant narrowing of RVOT with minimal antigrade flow. So we discussed something called suicidal RVOT. So you can see the RVOT is barely opening. It has clamped almost with severe RV dysfunction. There was echo contrast spontaneously going. So RV was a bad RV, which required inotropic support and putting IV central line. Patient was put to BiPAP. 4 days down the line of intense continuous monitoring, the child slowly settled down, the saturation slowly improved, and the RV function better. You can see the RVOT flow slowly improving from the completely occlusive RVOT. We discharged the child on day 7 after 5-day ICU stay, and we can see the RVOT flow, a decent one with mild PR. The gradient by echo was only 26 during discharge. In 3-month follow-up, we found RV significantly improved with a very better function. The RVOT in 3 months even better. It looked very good flow. So RVOT and RV remodeled during this 3-month follow-up. This is the same child who was extremely sick, wheelchair bound. He had a stylish colored hair, playful. So in conclusion, we wish to state the valvular PS is usually a cyanotic heart disease, and newborn only it presents as severe cyanosis. Adolescent presenting with cyanosis and failure, extremely rare. Detailed evaluation and intense management is required for the proper diagnosis. Thank you once again. My sincere thanks to the organizing team for having such a wonderful session. Thank you, sir.